Welcome friends to MD Talk. It's a health platform for the doctors and by the doctors. In the academic wing of MD Talk, we have a collaboration of Indo-US talks on various medical topics ranging from recent advances to management to clinical dilemmas in all specialties. Today our topic for MD Talk is major depressive disorder, which we felt was apt in the pandemic scenario and its implications, health-wise and socio-economic. Also, 10th October coming in, which is our World Mental Health Day. Today we have two speakers amongst us, Dr. Ashutosh Shah from Mumbai, India, and Dr.Neha Badheka from US. What we are going to do over the next 1 hour is let each speaker express his views for 30 minutes each, and then we can have a panel discussion amongst both of them. Yeah. Ashutosh, can you hear me? Yeah, good. So we have Dr. Ashutosh Shah on the screen with us. As I mentioned, he's from Mumbai, India, and he has a work experience of 23 years as a visiting consultant psychiatrist, currently at HN Reliance Foundation, HD Gandhi Hospital for Mental Health. He's into clinical research and clinical trial management at global and local levels, especially with work experience in Singapore. He has done his MBBS in 1996, followed by DPM and DNB Psychiatry. He has a postgraduate diploma in medical legal sciences, and he has an MBA to boot from NUS in 2016. Just last year, he has had 8 public and professional presentations, and he also has 7 publications in national and international journals. Over to you, Ashutosh.
Thank you, Ritesh, and thank you, MD Talk, for inviting me on this topic. And also, I would like to welcome Neha, who will be my co-speaker on this topic. So let me start by sharing my screen. Okay. So the agenda for today on major depressive disorder, what I'm going to do is over the course of next 30 minutes, go through briefly through epidemiology, followed by etiology and pathophysiology, the clinical features and diagnosis, and the treatment of major depressive disorder. So moving on. Okay. So moving on over here. In terms of epidemiology, the average annual incidence of major depressive disorder is around 6%. And if we look at the population, almost 20% of the population, that means 1 in 5 individual, would have a lifetime prevalence of this depressive disorder. And the prevalence is similar in developed and developing countries. So on this particular bar chart, you can see that some countries are a little bit more than the others, but overall if we compare, all countries are comparable in the incidence and prevalence of this disorder. The median age of onset, the severity, symptom profile, the demographic characteristics are again comparable across countries and cultures. And the discrepancies that are there between the countries are actually in terms of the resources and the treatments that are available. Well, this difference is actually very visible on the slide now. At least half the population in the developed nations would be having a proper treatment, whereas in the developed countries, less than 10% of the patients have an access and solution for their depressive disorder. So this is the major discrepancy in terms of resources and treatments. Moving ahead on epidemiology, of course, the risk is twice for post-pubertal women as compared to men. And in both the genders, the median reported age of onset is around 25 years, with a peak risk between the ages of 15 to 40 years. So you can see this disorder really targets an individual right in the prime of his life. And of course, it hampers the development of the individual and at a societal level has a major economic impact. Consistently, the environmental factors that are reported in both the genders, I'm not going to read them out, they are on the screen. But what I would like to say over here is that the cause-effect relationship is not very clear. So it's an association that we have noticed that somebody who has a recent negative life event. So in the view of the pandemic, there may be a lot of negative life events occurring, but that's not necessarily causational It's just association with the increased incidence and prevalence of major depressive disorder. In terms of the disease course, it's a very pleomorphic course. So different individuals may have different trajectories of the disorder. But what we do know is those with comorbid psychiatric illnesses or very intense severity of their disorder or a history of childhood trauma, these are the population which would have a less favorable course or outcome of the disorder. In the community and outpatient care setting, there is slight difference. So if one sees the slide, one would feel that a patient visiting the healthcare setup tends to do less well than those who do not. But that's not obviously the case. The reason is those who are not really feeling that well are the people who are going to approach the outpatient care settings and try and seek treatment. But of course, their intensity of the illness is more than somebody sitting in the community, and he may not appreciate, he or she may not feel the need to actually go and seek treatment. And that is why there is this artificial difference where it appears that the community setting, the course of the disorder is better, the prognosis is better as compared to the outpatient care setting. What is important is the nature of the disorder is recurrence. So even if a person remits, and by remission we mean complete recovery from the disorder, there will be some residual symptoms and functional impairment which will remain. And almost 80% of the patients experience at least one recurrence in their lifetime. So it's not a disorder which comes and goes and then never happens. It's a disorder which comes and goes and then tends to keep on coming again and again, specifically at time points when the individual is experiencing a stressful situation. In terms of the disease burden, so as per the WHO, the disorder ranks numbered second in terms of the contribution for the global disease burden, which is expressed in the disability adjusted life year or DALY. And by the year 2030, WHO projects that this will be the number one cause of disability globally. In terms of mortality, it increases the risk of death by at least 60 to 80%. And of course, the onset of major depressive disorder is a gateway for other somatic illnesses. On the screen, you will see a relative risk of, let's say, 1.8 for having mortality or heart disease or even diabetes mellitus at 1.6, and even obesity, cognitive impairment, cancers, and disability. By itself, major depressive disorder contributes to all cause mortality is 10%. So definitely it's a disorder which has a lot of economic impact, a lot of health impact, and of course even increases the risk of other somatic illnesses and mortality. So having seen this about the epidemiology, let's shift to etiology and pathophysiology of this disorder. So in one word, the etiology is multifactorial. We cannot put a finger, okay, this is the reason that genetics is the cause or any environmental factors is the cause. No, it's not the case. It's not so simple. I will be briefly reviewing all these topics in the coming slides. Starting with genetics, what we do know is that first degree relatives of patients show threefold increased risk of major depressive disorder. And this is not new. This is something which is known for more than a century now. What we do know is that heritability of this disorder is only quantified as 35%. And the genetic overlap between the risk for major depressive disorder and other psychiatric disorder exists. And the risk is polygenic. So the genes involved are very having a small effect. And in fact, in genome-wide association studies, we have found at least 108 independent loci, which have been shown to increase the risk for developing this disorder. Apart from genetics, the epigenetics, that means the molecular mechanisms underlying the gene environment interaction. And here, an example is this FKBP, that is the FK506 binding protein. That is an allele which is present. It increases the demethylation, a stress dependent DNA demethylation. And in this situation, what happens is eventually there is increased expression of this FKBP5 in the brain in response to stress. And these leads to a glucocorticoid receptor resistance. Now, what is the impact of this? I'll show you in the slide when I talk about the HPA axis. And there are consistent epigenetic changes in the brains of animal models as well as post-mortem brain samples of patients with major depressive disorder, and specifically in suicide victims who were exposed to early life adversities. What we do know is that the epigenetic research in major depressive disorder, or depression as we call it colloquially, is only less than 10% as of now compared to, let's say, another medical disorder such as cancer. So we really don't know much. The data is still coming in. Moving ahead, in terms of neuroplasticity, so we do know that the brain tends to regenerate, the neurons tend to regenerate, and the process of this neurogenesis, and that is where it is impaired, specifically in the hippocampal area of the brain. And what is known is that there is a lower level of the neurotrophin, the brain derived neurotrophic factor, in the serum of patients with major depressive disorder. So at a biological level, neurogenesis promotes resilience. That means giving a fighting reply to stress, the ability to combat stress, and that is reduced. Whether this neurogenesis, which is reduced right from the beginning or towards the end of treatment or the disorder, we don't know. But we do know that neurogenesis contributes to the effects of antidepressants in humans. For the gene environment interaction, so there are relevant genetic variants which either increase the risk or they reduce the risk of this gene environment interaction. And there are several candidate genes. Some of them I have listed on the slide. But what happens is there is a difference in the timing and the type of adverse environmental circumstances. And therefore, this has hampered the replication of the single candidate genes. So again, we cannot put a finger on one particular gene. And this is a simple representation. So an individual has a genetic vulnerability. There are epigenetic mechanisms in terms of the environment. There are these aversive risk factors and some protective risk factors. And that determines eventually the onset of major depressive disorder. And that has an impact at a behavioral level, at a brain network level, and at a molecular level. In terms of the HPA axis, so the HPA stands for the hypothalamic pituitary adrenal axis, and this is the axis which has been very well researched in terms of the neuroendocrinological aspect of major depressive disorder. And early life stress leads to a persistent increase in the activity of corticotropin releasing hormone containing neural circuit. And what this does is that alterations in this axis correlate clinically with impaired cognitive function and then results in more severe and pronounced symptoms in the depressed patients. And of course, these patients tend to have more of melancholic and psychotic features. And also in the elderly patients, one will find a lot of HPA axis alterations. So although we know a lot of details, for the simplicity, I have not included them over here. But what we would like to say is that despite knowing a lot of these details, we still don't have new therapeutic avenues. So I had said in the previous slide that there is a glucocorticoid receptor resistance. So that means there is increased cortisol which is there in the patient's blood. In the brain, the receptors do not tend to have a negative feedback despite the fact that there is increased cortisol. And this has adverse consequences. So this is a simplistic representation. These are the signs and symptoms of the disorder. In terms of the CNS, there is altered neurotransmission. There is reduced neuroplasticity and impaired neurogenesis. And this at the hypothalamic pituitary level. So this is where it has an impact and the feedback regulation is impaired. And that results in a lot of physiological changes, specifically in the cortisol levels. Of course, this is in a subset population. Moving ahead on the etiology and pathophysiology, we know that a subset of patients of major depressive disorder tend to have immune system disturbances. And over here, one important point is the brain is the master which is controlling all the systems of the body. And that is true even for the immune system. So the HPA axis, the autonomic nervous system, the central nervous system, they all interact with the immune system in a mutually regulatory feed forward and feedback loops. And this is what is the circuit, the previous diagram that I had shown. So from the hypothalamic axis, there is also a regulation of the immune system. And now in the pandemic time, everybody is now very well versed with interleukin 6, TNF alpha, but we know that for ages, a subset of population of major depressive disorder tend to have increased levels of TNF alpha and interleukin 6 in their blood. And of course, this is a potential biomarker for major depressive disorder. Not yet in clinical practice, but definitely in research. In some subpopulation, we do see these levels are altered, and even the immune system functioning is gone haywire. And that would be an explanation why some people with depression tend to have repeated infections, and why after the successful treatment this tends to reduce, because the immune regulation is improved. So I will not again repeat what I've already said, but what we have already known is that PET imaging studies has indicated neuroinflammation and microbial activation in the CNS of patients with MDD. Of course, not everybody, but a subpopulation which definitely tends to have this neuroinflammation, which is picked up on the PET imaging studies. In terms of the monoamines, so let me come straight to the last point, and that is most important. Most of us who have been in practice for more than 2 decades now would remember the monoamine hypothesis. That means reduce serotonin or reduce dopamine. Let's forget this. This chemical imbalance theory is completely outdated. Why? Because we know that when we give the medicines, the so-called antidepressants, the monoamine levels tend to peak within hours of administration, but the antidepressant effects tend to happen only few weeks down the line. And of course, this is not a result of increase in the monoamine. This is because of a brain gene expression which changes and restores neurotransmission. And that is the real reason why the drugs bring about a therapeutic effect. So forget if you have anything in mind about brain chemical imbalance or reduced levels of serotonin. All that is outdated. Coming to structural brain changes, so over here, all the previous molecular and cellular mechanisms, they contribute to certain brain structure changes. And the most well-known thing is about structural MRI studies and the hippocampal volume. And this is known that people with major depressive disorder have a reduced hippocampal volume. And other things, some people may have orbital cortical thinning in the orbitofrontal cortex, or in the cingulate cortex, or in the insula, or in the temporal lobes. But whether the hippocampal volume reduction happens early in the course of the disorder or later, that is not known. But what is the good news is that successful treatment tends to reverse this reduction, and therefore tends to show improvement in the individuals. And the last point about the etiology and pathophysiology is the functional brain circuitry changes. Of course, this is a bit complex for specifically non-psychiatric population, so I'm not going into details, but what I would like you all to remember is that there are different brain circuits, and there are the three that I've shown on the slide: the affective salient circuit, then what we call the default mode network, the medial prefrontal medial parietal default mode network, and the frontoparietal cognitive control circuit. And these tend to be haywire. So what happens as a result is, in the first circuit, the affective salient circuit, when this does not work as it should, what happens is the information, then specifically the negative information, tends to be given more emphasis by an individual, and even self-directed thoughts. So the individual tends to blame himself for anything happening in his environment, and anything negative in the environment is definitely the biggest chunk of information that the individual retains. So no matter what good happens in his life, he doesn't remember that or does not put excessive emphasis on that. The other, the default mode network, the abnormality manifests as increased rumination. So rumination is recurrently remembering specifically the negative life events, and then excessive self-focus. So the individuals tend to have a lot of focus on any somatic symptoms and tend to be very anxious that are they having some somatic disorder, and they keep repeatedly approaching the doctor saying that something is wrong, something is wrong. You do all tests that possible, and there is nothing which is found wrong, yet the individual says no, something is wrong in the body, I don't feel fine, I don't feel energetic. And the reason is actually the default mode network is not really working well. And the frontoparietal cognitive network, over here the abnormalities in depression result in reduced goal directed attention deficit. In short, the motivation of the individual tends to go wrong or go down, and they have inappropriate cognitive appraisal of negative events. Again, that means they give an emphasis on anything negative and they just cannot see the positive side. And these are actual changes in the brain circuit. So having seen so much about the epidemiology, the etiology and pathophysiology, let's shift to clinical features and diagnosis. So the first point I would like to emphasize over here is there's a lot of confusion, not only in the medical people and the lay people, but sometimes even among psychiatrists, whether the depressed mood and major depressive syndrome, these are not synonymous. So what do I mean over here is that there will be some fluctuations in our mood. We tend to be happy when there is some good event. We tend to be sad and upset when there is some bad event or not good event. And that's perfectly all right. What happens is that when we have a sustained depressed mood, that is pathological. And another point is most people with low mood do not have major depression. In fact, a large proportion of major depressive disorder patients do not have low mood. Having said that, what is that? That is the core of the symptom in those with depression, and that is impaired capacity to experience or anticipate satisfaction, what is known as anhedonia, or the symptom of diminished interest or pleasure. This is the central symptom of people suffering from major depressive disorder. What happens is that they say abhi kuch dil nahi karta hai. In Hindi they call this niras. You know, कुछ दिल नहीं करता है. सब लोग आते हैं, बात करते हैं, लेकिन फिर भी अच्छा नहीं लगता है, उनके साथ बात करने को दिल नहीं करता है. This is actually the very typical symptom of people suffering from major depressive disorder. Another point I would like to emphasize over here is that depression is a highly heterogeneous syndrome. So I'll take a moment to explain the classification in psychiatry is not etiological, it is phenomenological. That means based on a cluster of signs and symptoms, we have diagnosed different disorders in the individuals. So this is exactly akin to where medicine was maybe a century or a century and a half back. You know, different kinds of fever, and then they would be classified as either having malaria or having other illnesses based on the pattern of fevers, of course without actually testing the blood, and that is where psychiatry is today. So everything is clubbed as major depressive disorder, but it can be highly heterogeneous and the underlying causes are completely different. And in terms of the classification, we have the two main classification systems in psychiatry. We have what is known as the Diagnostic and Statistical Manual of Mental Disorders, that is the DSM-5, or the International Classification of Diseases from WHO, the ICD-11, the current version. And in terms of diagnosis, we need at least 5 out of the possible 9 symptoms that I'm going to show you in the next slide. And simple permutation combination in arithmetics will tell that there can be at least 256 unique symptom presentation, and all of them are classifiable as major depressive disorder. So in short, no two patients of major depressive disorder would have identical symptom profiles. And this is what is really confusing for many non-psychiatrists. So in terms of classification and the diagnostic criteria, I'm not reading the slide out, but what I will say is that at least one of the two, depressed mood or markedly diminished interest, this has to be mandatorily present and present for at least the same 2-week period, nearly every day, and should represent a change from the previous functioning, accompanied by at least minimum 4 of the next: change in weight, change in sleep pattern, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, diminished ability to think, or recurrent thoughts of death. So an individual may just have 4 of these or may have all the remaining 7 of all the criteria. And based on the number of symptoms, we would then classify as having mild, moderate, or severe intensity of depression. Of course, before we do that, we also need to ensure that the symptoms are causing significant distress. So if somebody is having these symptoms but is able to work and has no impairment in either the social or occupational areas of functioning, then we do not give a diagnosis or we do not treat at that point in time. And definitely the episode is not attributable to a physiological effect of a substance or another medical condition. So somebody with hypothyroidism could jolly well have all these symptoms. But then if we know that it's the thyroid abnormality which is causing the symptom, then we do not diagnose it as major depressive disorder. Rather, one would give the thyroid supplements and then observe after the thyroid levels have normalized. If yet the symptoms are still present, then only we would give a diagnosis of major depressive disorder. And definitely, we have to rule out that this episode is not occurring in the context of another psychiatric disorder like bipolar mood disorder or schizophrenia. And then, of course, the severity, the anxious distress, mixed features, melancholic, psychotic, peripartum, and seasonal pattern. These are the specifiers of the major depressive disorder. So having just seen all this criteria, it should not appear that we are just ticking, okay, you are having this symptom, you are having that symptom, and then say you are having that disorder. No, we also look at the mental status examination. We see the individual. Are they sitting straight or are they slouched? Are their face going down? Are they having downward gaze? Are their movements slow? Are they able to move fast? Look at the brow. Is it furrowed or are they changing? Is the speech monotonous or they melodious? Are they able to remember or are they complaining that, doctor, I cannot really remember. I have difficulty even remembering or even reading half a page of the newspaper. All these points in coherence, and definitely we include a family member both for corroborating and giving us additional inputs and also partnering in the treatment, because this individual may be able to take care of the person suffering from major depressive disorder. I again repeat, we need to confirm that the depressive episode is not part of a bipolar mood disorder, and that is done by asking specific questions like, have you ever felt in your life a distinct period where the mood was very elevated or you felt terribly happy for no rhyme and reason? Along with that, you did not feel the need to sleep. You started phoning up people in the middle of the night, or you started doing too many things and left them incomplete, or you felt very angry, you felt very energetic. All these should be raising the symptom suspicion of a bipolar mood disorder. If that is the case, this individual is having bipolar depression, and that is completely different from what we call the unipolar major depressive disorder. Apart from all this clinical diagnosis, we also tend to have a standard workup. We do a complete blood count, thyroid screen, the fasting and postprandial blood sugar, the liver kidney function test to detect any systemic illness, both whether this is also responsible for the symptoms, or B, when we give the medication, the individual is having the organ systems well working to be able to tolerate these medication. And of course, a baseline lipid profile and ECG with QT-QTC interval is also something which is routinely done. In some cases, we tend to do vitamin B12 or urinary drug screen to rule out any substance abuse or dependence, and that is only if we suspect, not routinely. And brain MRI or CT scans are not default done in every individual, but only in individuals where we are suspecting an underlying cerebrovascular accident or another structural brain changes which could be responsible for these kind of symptoms. Coming to treatment, over here I have made this classification. This is not carved in stone, but arbitrarily at a primary care level, which are the population of patients that can be treated by the primary care physician or non-psychiatrist. So over here, an individual of major depressive disorder experiencing this for the first time in their life, and of course not having suicidal risk, this population can be treated. Somebody with mild to moderate intensity of major depressive disorder, this also can be treated. And in individuals with good social support, these individuals also can be treated at the primary care level. And when is it that the patients can be referred to a psychiatrist? Over here is the population which has recurrent major depressive disorder, or what we call difficult to treat, previously what was known as treatment resistant depressive disorder. Secondly, those who are having moderate to severe intensity of major depressive disorder, specifically those having suicidal risk factors or actually at risk of attempting suicide. These are the individuals who should be urgently referred to a psychiatrist. And those who are having comorbid psychiatric disorders or drug dependence, these cases will be difficult to treat at a primary care level, and we need a specialist input. Coming to the treatment itself, so there are some terms which I have explained on the slide: response, remission, and recovery. In clinical parlance, we say a response just simply by asking the patient how much better does he feel and which symptoms have improved, as compared to day 0 when the treatment was started. And in research, response is categorized using scales such as the Hamilton Anxiety or the Hamilton Depression Rating Scale or HAM-D, or the Montgomery-Åsberg Depression Rating Scale or the MADRS. And then of course quantifying the response as having 25% reduction or 50% reduction compared to the baseline score. When we say remission, it implies that the patient was assessed for elements of major depressive syndrome today, and based on that, the symptom threshold is not reached. So if you recollect, the diagnosis required 5 out of the possible 9 symptoms. And assuming that the treatment was initiated, and couple of weeks down the line, we check the symptom profile again, and we see that the individual is no more completing or fulfilling the diagnostic threshold, then we would say the individual is having remission. But yet, when we say the individual has remitted, it does not mean that he has recovered. Recovery will mean return back to a baseline. And in the next slide, in terms of a graph I have explained, so when the individual tends to develop the symptoms of depression, this is the nadir of his symptoms. He comes to a clinician, and then the clinician starts his treatment, and the individual shows some response, but he is still fulfilling the criteria of major depressive disorder. And couple of weeks later, he tends to have a remission. That means he does not fulfill the criteria for major depressive disorder. And then eventually, a couple of months later, he is recovered. That means he is working as before the onset of the symptoms in terms of his socio-occupational working. And this is where the issue is that most of the patients do not recover. Specifically, the more number of episodes, the less chances of recovery. And this is the reason why major depressive disorder is the number 2 on the disability adjusted life year list and is projected to be number 1 by the next decade. And then of course, once the individual has recovered, we need to focus on preventing recurrence. And before recovery, if the individual tends to have the full-blown episode, we call it a relapse of the disorder. And accordingly, the phases of treatment are kind of arbitrarily separated into acute stage, the intermediate stage, and the long term. So when the individual comes to the clinic, the number 1 over here, from the time of starting of treatment until remission, is what is known as the acute stage. And this may take at least 8 to 12 weeks. That means anything between 2 to 3 months to achieve symptom remission. Intermediate, that means once the individual has remitted, we focus on continued treatment and functional rehabilitation, which may last up to 24 weeks or 6 months. And then of course, specifically in those with more than 1 episode, we tend to have long-term maintenance treatment, and in some cases lifelong, in order to prevent a recurrence of the disorder. Now, the next 3 slides, including this one, I've just enumerated all the different classes of antidepressants which are in the market. We have more than 2 dozen antidepressants. Theoretically, we have almost 70 molecules which will have antidepressant activity. We need not go into that detail. Usually at a primary care level, I would advocate that fluoxetine, paroxetine, sertraline, and escitalopram, the usual doses over year and the common side effects. This, if an individual can remember and master, that will be great. So only these molecules which I have highlighted in blue color at a primary care level, this is where the individual needs to familiarize themselves. The dictum is start low and go slow. So if fluoxetine, the usual dose range is 20, you do not start straight at 20. Maybe you start at 10 milligram and then gradually up titrate. And the chief complaint with fluoxetine is going to be GI distress. So ensure that fluoxetine is given at least half an hour after a meal, maybe in the morning, half an hour after breakfast, specifically because fluoxetine can also cause insomnia. In some cases, it may increase the anxiety in the first few weeks. So in this situation, one may give low dose benzodiazepine, but not more than 4 weeks, and then subsequently stop the benzodiazepine, because fluoxetine itself will have anti-anxiety action. Another good molecule is paroxetine, which has a good anti-anxiety action and good antidepressant action. One can start the control release formulation. So this dosage is for the plain formulation between 20 to 60. The control release formulation has 12.5 milligram strength. One can start with 12.5 milligram either in the morning or at bedtime. And most importantly, it should not be consumed on empty stomach. So for GI distress, some people may have nausea. One could give symptomatic pantoprazole or any other antacid, or one can also use ondansetron as an antiemetic in this population for the first maybe 10 or 20 days and then gradually stop it. So the next slide, I've just given the other antidepressants, and the third slide where I've given the other antidepressants, including the common side effects. But mind you, some molecules should not be prescribed at a primary care level, specifically molecules like venlafaxine, these and desvenlafaxine. These are best left to a treating psychiatrist. They are not very simple in terms of their pharmacological mechanisms. This is a simple diagram. Of course, it's very complicated on the screen, but what is the purpose of this diagram is to show different molecules having actions at a presynaptic receptor level and some having actions at a postsynaptic receptor level. The end point is the neurotransmission is restored a couple of weeks after the molecules are taken. Now, this is a diagram I've borrowed from a 2018 meta-analysis of antidepressants, which has done the real world kind of data, wherein efficacy and acceptability have been mapped. And based on this, the molecules which are recommended are shown in the middle of the screen, beginning with agomelatine, amitriptyline, escitalopram, mirtazapine, sertraline, paroxetine, and vortioxetine. So no matter a molecule which has a very good efficacy, for example, amitriptyline, it may not be tolerated well, or that is the acceptability. So on acceptability, actually amitriptyline is quite low. In terms of acceptability, agomelatine is high, but in terms of efficacy, it is not high. So what is important is to have a balance that the molecule has good efficacy and at the same time good acceptability. That means low adverse event profile. Now, other than medicine, it is important, and this is very much important, that one needs to explain the patient what is really happening to them. The point in bold that I've put over here is to tell that depression is a medical disorder which is treatable. There are lots and lots of myths pertaining to depression or major depressive disorder, both within the medical fraternity and the general public. The biggest myth is that this is a phase of life problem which can be overcome by willpower. That is not really the case. It's an actual disorder of the brain. And just like any other medical disorder, be it diabetes or hypertension, it needs to be treated with medicine. That has to be drilled very, very clearly, no ambiguity about it, that this is a disorder of the brain. It is not a fault of the individual. It does not indicate weakness of character. It is definitely treatable with medicine. And other than that, it is important to tell the patient that you cannot do miracles. If you start a treatment today, they will not start feeling well before a couple of days or weeks. So patients have to be informed that they need to be compliant with the medication and they need to have a little bit of patience before they start feeling the benefit of the medicine. And other than this, their caregivers also need to be explained and taken into confidence. And most importantly, encourage healthy lifestyle. So it is not just isolated medical treatment. What do we mean by healthy lifestyle? Avoiding junk food, avoiding sleep. That means some individuals tend to tinker with the sleep late in the night. That should not be done. Minimum of 6 to 8 hours sleep at night, regular exercise. These are all to be encouraged in combination with the medical treatment. And of course, if an individual is in need of specific psychotherapy like a cognitive behavior therapy, this could be taken from either a psychiatrist who's trained in this or from a psychologist who has a training in this cognitive behavior therapy. And then coming to the almost the end of the presentation, the discontinuation of treatment. So remember when we said starting treatment has to be at a low dose and slowly up titrated till the patient shows a good response. Coming down when the time comes to stop the treatment. So at least for the first episode of major depressive disorder, the WHO recommends to continue treatment for 6 months after the patient is 100% recovered. That means on an average, we are looking at 2 to 3 months for the remission and then subsequently 6 months. So we are looking at least a minimum time frame of 8 to 10 months of treatment with an antidepressant in somebody who has had a first episode of major depressive disorder. And then subsequently one has to taper. And taper doesn't mean that you go very fast or very slow or you abruptly stop. No, the decision has to be taken based on how severe was the disorder. Was it the first episode? Did the individual have more than first episode? Are there other comorbid disorders? Is the patient having a good support system? Is he still having a coping mechanism? And then we need to taper over a period of few weeks to few months. And then gradually with follow-up to ensure that the patient is not showing a signs of recurrence after the resolution of the symptoms. And some symptoms may happen when we discontinue, what we call the discontinuation syndrome. And these are flu-like symptoms, insomnia, nausea, or hyperarousal. If it is mild, just reassurance suffices. If it is mild to moderate, symptomatic treatment like analgesics, antiemetics may be beneficial. But if the patient is complaining severe symptoms, then we need to restart the previous dose and then go down very slowly, maybe over a few months before we stop the antidepressants totally. So even after the treatment has been stopped, the patient should be reminded that they remain at a risk for a relapse. And definitely this risk is higher than the general population. And whenever the patient is undergoing a stressful situation, they should be reminded of the early signs of the disorder, the relapse, maybe sleep disturbances, appetite disturbances. And if that happens, they should come back to you and not wait for the full-blown disorder to happen. And then if that is the case that the patient does get a recurrence, then go back to the previous treatment which worked for the patient. And that should help the patient again reduce the symptom profile. So having had this overview, I would like to thank you very much for your attention. And I would like to stop over here.
Thanks, Ashutosh, for a very lucid talk. And don't go far away. You can definitely take a coffee break now. We have 30 minutes for the next speaker, and then followed by a panel discussion between both of you. Okay.
Sure. Thank you.
Welcome, Dr. Neha Badheka. It's my pleasure to introduce Dr. Neha. She's a board certified internal medicine physician practicing for the past 10 years. She has done her internship in psychiatry followed by residency in internal medicine. She's a certified CDL medical examiner and a certified MRO. She heads the occupational health service department at a private company in Pennsylvania. Just the background, she's done her MBBS from KM Hospital, GS and GS Medical College, followed by a psychiatry internship at the Mayo Clinic. She's done her internal medicine residency at Rochester General Hospital. She's been a consultant physician for Amwell and has held various posts as attending physician, as hospitalist, and urgent care clinic in New York and New Jersey. She's in charge of occupational health department in PA. Over to you, Dr. Neha.
Thank you, Ritesh. I'm going to share my screen now. And just bear with me.
Yeah.
I think.
Yeah, you're good to go, Neha.
Yeah, I'm trying to see how I can move this screen forward. Oh, there we go. Okay. Thank you. Thank you, Dr. Ashutosh Shah. That was a great presentation, great overview. And I definitely learned something new ever since I graduated from medical school way back in 2003. Lot has changed, so it was definitely a great presentation. I'm a general internist and practice general internal medicine and primary care. And today I'm going to focus a little bit on depression in primary care. We will take a quick look at the global burden of the disease, some epidemiologic facts, risk factors of the disease, mainly screening for depression in primary care, how to identify patients, when to screen, and an overview of some of the screening tools you can use to screen for patients with depression in primary care setting. And some of this might be a bit of a repetition that Dr. Ashutosh has already mentioned, but we'll just quickly go over this. So the global burden of depression is quite staggering. As per the WHO, 4.4% of the world's population has depression, and the increase in the rate of depression has gone up almost in a linear pattern over the past several years. Between 2005 and 2015, in a span of 10 years, the rate increased by almost 18 to 19%. It is also one of the leading causes of disability worldwide. When we talk about disability, the physical aspect of disability is the one that comes to the mind. And rarely do we think about mental health and mental health disorder as being a cause of disability. And this is very important to know that depression is actually a major cause of disability in any country, developed or underdeveloped country. Suicide is also a leading cause of death in 15 to 29-year-olds. This is also a surprising statistic and important one to keep in mind. Also, a lot of patients in low and middle income countries who have depression receive no treatment for the disorder. And the numbers are pretty staggering. Almost 85% of patients who do suffer from depression receive no treatment whatsoever, which is, again, quite a dismal figure. This table here just highlights the global burden and in the disability ranking, and you can see major depressive disorder is number 2, which we don't usually think of that when we think of conditions that cause disability. These are conditions contributing to YLDs, which are years lost to disability, and depression is right up there amongst other conditions. And to note, anxiety disorders is also in there at number 7. So mental health overall is a major factor. As we saw, 85% of people in middle and low income countries are not treated, and there are a lot of barriers to care. Of course, lack of resources is one, but also lack of trained healthcare providers. As a general internist, I can tell you that the level of comfort that most primary care providers feel in terms of identifying mental health disorders and initiating treatment is definitely not up there. I think we need more education and awareness in primary care providers to identify these disorders, either initiate treatment or initiate appropriate referral to a specialist. Of course, the social stigma associated with these disorders is, we're all well aware of that. As Ashutosh mentioned, a lot of stigma that you just have to gut it out. You just have to be, brave enough, or, admitting to the symptoms shows weakness. So all these things associated with the diagnosis can definitely make cause for a hindrance for diagnosis. An inaccurate assessment. Sometimes the symptoms are chalked up to other disorders and diagnoses as opposed to depression. So being able to pick up the symptoms and attribute it appropriately to major depressive disorders is very important. Now this slide, I'm just going a bit more into epidemiology, which we have already covered. Important to note here is that it's twice as common in women as in men. So women are more likely or more at risk for depression as opposed to men. It can occur at any age. We've seen that suicide being the #1 cause in 15 to 29-year-olds. So it can definitely start at a very young age as well. Often it begins in the 2nd or 3rd decade. And it has an important bidirectional relation with chronic physical disease. This is important to remember as a general practitioner, and we come across chronic medical conditions and we treat chronic medical conditions all the time. And depression has a very important bidirectional relationship, as in the chronic medical condition can be causing depression, as well as the incidence of depression per se as a diagnosis is higher in patients who have chronic medical conditions as opposed to patients who don't. This was corroborated based on a study that was done over an international study that spanned over 60 different countries that found 23%, almost 23% of patients who have comorbid medical conditions had depression, as opposed to only 3.2% of people that did not have these conditions. So again, almost a quarter of these people will have depression that have chronic conditions. So having talked about that, let's look at the at-risk population with comorbidities. As a general internist, we come across these medical conditions quite commonly, and a lot of these conditions have a higher rate of depression than in the general population or population without these medical conditions. Congestive heart failure is up there, almost 8%, so is hypertension. Diabetes, as Dr. Ashutosh mentioned, 9.3%, coronary artery disease. COPD, very common, again, it's very high, 15%. End-stage renal disease, very high. A lot of these patients can be on dialysis, which adds morbidity and can also be contributing to their depression. Neurologic disorders are also very up there. Stroke, epilepsy, multiple sclerosis, extremely high numbers of depression, almost 30%. Another disorder is Parkinson's disease, very important. Almost 40 to 50% of these patients have depression, and that's extremely high numbers. So when you are looking at these patients from a primary care perspective, it's important to remember this. So briefly about risk factors of depression, and this will help you zero in on what patients you should screen for, what patients are at risk, and hence you should be screening for depression. One is previous episode of depression. Depression can be a recurrent disease, as Dr. Ashutosh mentioned. Almost 60 to 70% of patients may have another episode. Age is important. Sex, women twice more common. History of other mental illness, history of substance abuse, polysubstance abuse, family history of depression or suicide, chronic medical conditions, which we briefly looked at, that have higher rates of depression alongside. Unemployment, some other social factors that contribute as unemployment or employment-related issues, poor social support systems, any life stressors, including loss of a spouse, divorce, loss of a child can be a triggering factor, and domestic violence is up there. Certain other symptoms can also present in primary care, which you can present, depression can present with these non-specific symptoms. We looked at some symptoms defined in the DSM-5, and these are symptoms we are well aware of. But in the primary care setting, the patient may not always tell you or come with these telltale signs of depression, like anhedonia, low mood, loss of appetite, other things. And it's important to recognize these. As you can see, these are very non-specific. You can have chronic abdominal pain, back pain, constipation, just fatigue, just feeling tired all the time, headache, sleep disorders, insomnia or hypersomnia, joint pains, neck pains, weakness. Sometimes patient will say everything hurts from head to toe, and there is no underlying organic reason behind these symptoms. So if you've done the workup, you've done your proper history, physical and workup, and there is really no cause identified, and the patient continues to have these non-specific vague symptoms, it can be a sign of underlying depression and should trigger you to screen for depression. So talking more about screening, the prevalence of depression or depressive disorders in primary care clinics, according to some of the studies, is almost 22%. So almost a quarter of your patients can have depression, but it's recognized only in 50% of these cases. The USPSTF, which is the United States Preventative Service Task Force, it has found good evidence to screen for depression in the primary care setting. It does mention that it improves clinical morbidity and outcomes, improves outcomes when treated. It does mention that screening is valuable and effective if you have the proper resources in place and have access to treatment and follow-up. So screening without the proper treatment and follow-up will not be as effective. The USPSTF also recommends screening adolescents from 12 to 18 years of age for clinical depression with proper systems in place. And as you can see, as a general internist, we do not encounter pediatric patients, but if you're a general family practitioner, you might be seeing pediatric patients in ages as young as 12 years can be susceptible to depression and should be screened for if they show any red flags or underlying signs of depression. So let's look at some of the screening tools. This is not an exhaustive list. It's some of the common scales used there. There's a lot out there, a lot more screening tools. The one that's most commonly used is the PHQ, which is the Patient Health Questionnaire tool. There is a PHQ-2, which has 2 questions, and PHQ-9, which has 9 questions for screening. There is also the Zung Depression Scale, Geriatric Depression Scale, mainly for geriatric patients, and Beck Depression Inventory. For sake of our talk today, we'll be focusing on the PHQ-9 as a screening tool. It's basically a depression module. It has 9 different questions, and each question the patient will answer from 0, which is not at all, to 3 nearly every day. And these questions are mainly derived from the DSM-5 diagnostic criteria, meaning symptoms like anhedonia and things like that. We'll take a look at the PHQ questionnaire in a bit. This was completed by, it was validated in a study completed by 6,000 patients in primary care clinics. So the questionnaire, its construct, and as well as the criteria were validated using this study in primary care clinics and OBGYN clinics. And if the patient had high score on the PHQ-9, they were then interviewed separately by a mental health professional, which is a psychiatrist, and using a general health survey. So the responses were corroborated and the diagnosis was then established. So it's a valid tool and the validity was tested in clinical studies in the primary care setting. So it takes 2 to 5 minutes to complete. It has 61% sensitivity and 94% specificity. The sensitivity increases with higher scores. The scores, we'll look at the scoring in a bit. Scores of 5, 10, 15, and 20 represent mild, moderate, moderately severe, and severe depression, respectively. What this means is it's not only a screening tool, but based on the score, it can give you an idea of how severe the depression is so that it will help you triage the patient accordingly. So this is the questionnaire. As you can see, oops. I apologize. As you can see here, these are the questions here, the 9 items: little interest or pleasure in doing things, feeling down, depressed, or hopeless, sleep disorders, energy, appetite, self-esteem, concentration, activity levels, thoughts about suicidal ideations or hurting others. So these are the different questions, and the patient will rate these symptoms on a scale of 0, which is not at all, 1, 2, or 3, which is having these symptoms every day. And this is the score down here. You can see based on the scoring, you can have mild, moderate, moderately severe, or severe depression. So when applied to your practice, usually a two-step approach is followed in many primary care clinics here. Most clinics use a PHQ-2, which is the 2-item questionnaire, because it's only 2 questions and it's really simple. And if that's abnormal, then the PHQ-9, which is a more detailed questionnaire that we saw, is administered. So PHQ-2 is it's ultra short. It has 2 questions about mood and anhedonia. And it's very sensitive. As you can see, it's 97% sensitive. Means it's a great ruling out tool. So it's a great tool to rule out depression. But if it's positive, you can see it's 67% specific, meaning if it's positive, it doesn't diagnose depression, but it needs more evaluation. That's what that means. It's a great tool to rule out depression. So that's the PHQ-2 with 2 items. One is little interest or pleasure in doing things, or anhedonia, which is what Dr. Ashutosh said, you know, kisi se baat karne ka dil nahi karta, things like that. So that's what that is. And then feeling down, depressed, or hopeless. And the patient again rates it on a scale of 0 to 3. Then moving on to the geriatric population, both the PHQ-2 and 9 can be used in a geriatric population. The PHQ-2 has almost a sensitivity of 100% in these patients, so it's again a great tool to rule out. Geriatric specific depression scales are also available, 5-item and 15-item. The 5-item is found to be just as good as the 15-item in many studies with equal sensitivity, almost 97%. The American Geriatric Society recommends using the PHQ-2 as the initial test or the initial screening tool. And if that's abnormal, then you can go ahead and administer the 15-item or the PHQ-9 as a follow-up screening tool. So this is the 5-item geriatric scale. Here it's a yes or no, and this is the rating based on the responses. And if you have a score of 2 or more points, it's a positive screen. This is a 15-item scale. Again, a lot of these questions here, mostly based on the DSM-5, you know, extrapolation of those symptoms. It's a yes or no scale. And I won't go into the detail of this, but it's there. And just a quick summary about these screening instruments. They are used to enhance the clinical interview. So when you find that patient has responded yes or scored high on the screening tool, it should trigger a clinical interview, clinic history, basically in-depth history about the symptoms. So it's not used to replace a proper history taking process. It should not be used for diagnostic purpose, as in it should trigger evaluation for depression with further detailed history and physical, as Dr. Ashutosh mentioned. So it's not that you've diagnosed depression and you start medication if they're abnormal on these scales. The primary care provider should always obtain a complete history of current illness, past medical history, family history, which we all do, current medications they're on. That is again very important. Patients who are on 3 or more medications are also known to have higher rates of depression. And also if you start treatment, you would want to know about drug-drug interactions, which can happen quite commonly with antidepressants. So full history physical is very important. History of psychosocial stressors, any recent life changes, employment history, all those risk factors that we looked at should be discussed at the interview, and risk factors and should be explored in the follow-up interview. And a positive screen should trigger an additional diagnostic assessment using the DSM-5 or the ICD-10. The depressive symptoms that do not meet the DSM-5 criteria could be due to other syndromes. Dr. Ashutosh already mentioned that, but this is just something to keep in mind. Sometimes patients can have dysthymic disorder, cyclothymic. It could be bipolar, which is very important to remember, or could be a bereavement process, or just a grief reaction. And important to rule out bipolar as a manifestation. Dr. Ashutosh talked about that a bit, but it's not always apparent that the patient is having a depressive episode and had a manic episode in the past. So it's important to go into that history a bit further. Certain medical conditions that can mimic depression should always be excluded. Hypothyroidism, as we saw, can definitely mimic a major depressive disorder. So measurement of a TSH level should always be done in these patients. Some basic blood work has to be ordered to rule out concurrent other medical illnesses. The American Geriatric Society recommends the following workup, mainly the TSH, B12 that we looked at, calcium, electrolyte levels, liver and kidney function test, urine analysis, and a CBC in older adults. But this is something that you can apply to any adult patient presenting with depression. This is some of the basic blood work you can order as it's clinically relevant in the setting. So that was all. And that was a brief overview of what depression looks like in the primary care setting and some of the screening tools. And thank you for listening.
Yeah. Thanks, Dr. Neha, for an excellent talk. Good. We have Ashutosh back after the coffee break. And I'm sure it's quite interesting when two experts look at a similar topic with a different lens. So even though there was some degree of overlap, still it was a lot of information to be covered. I'm sure you two guys are practicing at different parts of the globe and will be having questions for each other too. So Ashutosh, any questions which you want to ask Dr. Neha, or Dr. Neha, you want to ask Dr. Ashutosh in terms of your practice and clinical dilemmas which you have? You can take it forward from here.
Let's start with Dr. Neha first.
Okay. No, that I had some questions. I know you briefly covered about when to refer to a psychiatrist from a primary care perspective. Is there anything you would like to add in terms of after listening to, the...
Sure. So first of all, excellent overview, Dr. Neha. I mean, it complemented what I already discussed, and you laid a very good framework for the primary care physician to evaluate using rating scales to objectify subjective complaints. So congratulations and thanks for that. Coming to your question as to when to refer. So there is no hard and fast rule. Let's look at it this way. When I said in my slide that a first episode depression is something which a primary care physician should be able to manage. Having said that, often the first episode depression may be an opportunity to refer simply for the sake of reconfirming the diagnosis. So let's assume that a 19-year-old individual lands up in the primary care and the physician suspects that this individual is having depression and would like to reconfirm. That is a valid reason. Of course, what is important is the therapeutic alliance with the patient. So the patient has to be first taken into confidence. Often the problem is not of the physician for referring, it is of the patient. That why are you referring me to a psychiatrist? Is there something wrong with me? So in this case, what needs to be emphasized is that we need to tell the patients why or what is the purpose of the reference. That's point number one. The second thing is, if after, let's assume that the physician has started treatment and there is no response whatsoever a month down the line, then that could be a valid reason to refer, because then that needs to be seen, why is the individual not showing any response. Usually after starting treatment, we expect at least 25% response in the first 2 weeks, 2 to maximum 4 weeks. If the individual shows no response whatsoever in the first 2 weeks after starting an antidepressant, it is unlikely that waiting any longer is going to be fruitful. Over here, a change of the medicine or a combination of medicines may be needed. And for some primary care physicians, this may be beyond their expertise, and this may be a valid reason for referral. Third, if after starting the treatment, what I would advocate is the physician who starts the treatment should carefully monitor the patient. Specifically, the first 4 weeks are very crucial. So it's important that patients are followed up at least weekly or every 10 days. Why? Because in some patients, there may be something what we call the activation syndrome. That means the patients tend to have certain activation syndrome, as in they feel psychomotor activity tends to go up. At the same time, the negative thoughts are still the same. And this is a risk that the patients may actually enact on their self-harm ideas. That means they may attempt suicide. So
Yeah.
if an activation syndrome occurs, or if the physician feels uncomfortable, that they are not pretty sure if the patient is at a suicidal risk or not, then that is a valid reason to refer. These are the cases that the physician can refer after starting the treatment. Some cases which I showed on my slide, which the physician can start referring straight away, would be those having a past history of bipolar mood disorder. That means the patient had a manic episode or a hypomanic episode in the past. Second, those without good social support or who are having adverse environmental stressors. These may be the patients for referral. Third, severe intensity of the disorder, or the patients are at actual suicidal risk. Other than this, there will be specific populations like geriatric depression, which you covered in your slide, because sometimes the geriatric population may present with what we call the pseudo dementia symptoms. That means they tend to complain more of somatic symptoms and cognitive complaints. So this becomes a dilemma. Is this dementia? Is this depression? And often it may not be very clear. In
Yeah.
such cases, it may be prudent to refer the patient. Another population would be the young, which you already covered, the child and adolescent group. Over here, what we know is that not every antidepressant tends to be efficacious. That indicated antidepressant is actually only fluoxetine globally, and in some parts of the world, escitalopram. So this population may need a different set of treatment. Another population would be population like, let's say example, pregnant women. This will be a population which needs to be referred, because managing depression in pregnancy needs an expert input of not only the psychiatrist but a gynecologist who is open to have a monitoring of the patient. And what we do know is that patients can be treated successfully with medicines during pregnancy. The outweigh, I mean, what we are looking at is the effect of the illness on the mother and the fetus and the side effect profile of the antidepressant. By itself, depression can lead to abortions, spontaneous abortions, may have, uh, fetal malformations or fetal low birth weight. All these are the complications of the disorder itself. We know that during pregnancy, the maternal interleukin 6, or what we call the cytokine levels, tend to be increased, specifically in the depressed population. And they are going to go and affect the fetal brain, crossing the placental barrier. So these population need to be referred early on. Other than this, if at any point in time the primary care physician is not really comfortable, I think they should go by that gut feeling. That if we are just not feeling that something is not right, that's the best case to refer. And reference doesn't mean that the primary care physician does not follow the patient. The specialist can give his advice. After stabilizing the patient, may ask the patient to follow back with the primary care physician. And that way, a therapeutic alliance can be built between not just the patient and the primary care physician, but also between the two care providers, the specialist and the physician. Because,
Right.
like you already pointed out, a quarter of the population which comes to the outpatient clinic could be having depression, but only 50% is picked up. So that means a large chunk really goes unrecognized.
Correct.
So,
Yeah, and I think the comfort and of the primary care provider, how comfortable they are treating and diagnosing and treating is important. And this is not something we are, sadly, everybody is comfortable as a primary care provider. It's definitely a challenging set of diagnoses. So as you
yeah.
said, I don't think there is any, if you're not comfortable, if you think this is not, that requires more expert intervention, I think referring earlier than later is always a good idea.
Right. Maybe I can take the opportunity to ask you a question, Dr. Neha,
Yeah, sure.
about your experience of, both diagnosing and treating major depressive disorder in the primary care level. If you could give us some insights into your real life experiences.
Absolutely. Yeah. I do. I do have more of a comfort, mainly because I have a bit of psychiatry background before my internal medicine training. So, um, but what that did for me is I was more aware of picking it up in my patients with chronic medical conditions, which I think the awareness and education of general practitioners to just have an open mind about mental health disorders in your general practice, um, and kind of be on the lookout is what's important. A lot of these patients will come with a lot of non-specific symptoms. They will not give you this ideal major depressive disorder presentation, as we saw the non-specific symptoms, right? Chronic abdominal pain, chronic headaches, which you cannot explain, chronic, joint pains. The workup is negative. We have tried several different medications. Nothing is working. And there's no explanation for the symptom. That should be a red flag to screen for depression, because it very well could be related to that. And in my experience, I mean, the geriatric population, we almost always screen. There are certain age groups that are high risk, mainly because they also tend to have more medical conditions as they get old. So we always, so we have a population we always screen, and then other patients we screen as needed, based on their intake and history. In terms of treatment, my first go-to is the SSRIs, the first line of medication. They've been around for a while. But as you said, it can be frustrating because it does take about 6 weeks for it to kick in eventually with the brain gene expression that you mentioned. That was good to know. That was great to understand that. So it does take 6 weeks for response, and a lot of times it's a trial and error. Sometimes you have to go through 2 or 3 different medications to come up with the correct antidepressant. So there is pharmacogenomics nowadays, but that's not accessible to everybody, which will tailor the treatment. But typically I start off with SSRIs of no contraindication. If there's no response, I do refer back to the psychiatrist, because again, then it's more of a trial and error and requires more follow-up. There are certain medical conditions that can be treated with antidepressants. And so if they have that along with depression, we tend to use it, like Cymbalta, which is duloxetine, used for neuropathic pain, fibromyalgia, chronic back pain. So, and these are patients that can also have depression. So it's a great drug there. For the elderly, we use Remeron or mirtazapine, which causes weight gain, which is what we want sometimes, and it causes sedation. So it's a great medication. Trazodone we use commonly in geriatric, usually give it at nighttime because it causes sedation and orthostatic hypotension. So that is something we typically tend to give at nighttime in that population. So these certain drugs that are go-to. But anything outside of that, as you said, anything that makes us think it's more of a complex, like a bipolar or mixed disorder, anything that's severe, moderately severe, severe depression, suicidal ideation, with hallucinations or atypical symptoms, catatonic symptoms, we refer to the psychiatrist.
Yes, I think you made a very few valid points in your drugs of choice for yourself. So I just revisit some of those points. I mean, yes, there is a therapeutic delay as of yet. So we don't have, and this is still an unmet therapeutic need. We do not have, fast-acting antidepressants. Of course, there may be some response, and one way to build a therapeutic alliance, other than being transparent with the patient that there will be a delay, what is important to tell the patient is sometimes they may experience side effect and we can turn the perception of this 360 degrees. We can tell the patient that if they experience certain side effect, it is an indication that the medicine has started to act. Of course, not severe, but let's say an individual is given fluoxetine and experiences mild nausea. We can reassure the individual and at the same time tell him that yes, the medicine seems to be working. Of course, if they land up with severe nausea, then that's not what we would be telling them. And this is one way to tell them that if they experience some side effect, it could be the beginning of the effect, because eventually the nausea is because the medicine is working on the serotonin receptor, the largest population which is there in the GI tract. So that is definitely not a wrong statement if we are going to tell them. It's just that we don't want the medicine to be acting there. That's point number one. Having said that, of course, there are some fast-acting antidepressants. I mean, there have been studies shown, so let's say with escitalopram, or sometimes what we call the combination of escitalopram with mirtazapine, which can have a faster onset of action within the first week. And this is definitely there that they may show a good response, and this is an indicator that they will definitely benefit with the continuation of the medicine. Other than this, what I would like to also point out is you mentioned mirtazapine. Mirtazapine is a very good antidepressant for the elderly in terms of efficacy and in terms of acceptability. Of course, but then this is within a specific dose range between 7.5 to 30. Going beyond 30 milligram, it may not be that efficacious. And the funny part about mirtazapine, at 7.5, it has a very higher sedating side effect. So here we are exploiting a side effect. So a person who's complaining predominantly of insomnia, we do not want to give this individual benzodiazepine. Mirtazapine is definitely a good point. Uh, Coming to benzodiazepine, and this is what I would like to emphasize. Often in the need to reduce symptoms overnight, physicians or sometimes even the patients tend to insist, give us benzodiazepine, Alprax or Restil or
Yeah.
lorazepam. But if I look at the elderly in at least in Mumbai, almost I would say 80 to 90% of the elderly are hooked on to benzodiazepines, specifically alprazolam.
Right.
Benzodiazepines very good in terms of efficacy, no doubt about that. In terms of safety, that's where the issue is. If we are going to start benzodiazepines, the practitioner needs to have categorical vision as to how long are they going to give, in whom we are not going to give. In a person who is having substance abuse or dependence, these are not the individuals to give. Those having underlying personality disorder traits, these are the individuals to avoid, specifically the borderline personality disorder traits, because we know they are more prone to A, attempt an overdose, or B, abuse the medication.
Right.
So, what I would like to use this platform to deliver a message. Antidepressants work, there is a latency. If one would like to use benzodiazepine as a patch cap mechanism, very good. But then ensure that in the time frame of 4 weeks to maximum of 8 weeks, these are tapered and totally stopped. And do not use it indiscriminately, because this is where the real issue is, that people tend to get dependent on benzodiazepine, and all psychiatric medication tend to get a bad name. Often the patients, their first question is, will I get dependent on the medicine? No. If we are going to give you antidepressant, you're not going to get dependent. But yes, if we are going to give you benzodiazepine, there are chances. And if we are using benzodiazepine, it may be a point to tell the patient why we are giving it, what is the expected side effect, and most importantly, warn the patients they should not drive vehicles when we are starting a psychotropic, be it an antidepressant or a benzodiazepine, at least in the first few weeks till the time that they are not comfortable, because it can impair their ability to drive vehicles. So these are some other additional points outside of our presentation. And
Absolutely. Yeah.
you did mention about the medicines.
Dr. Ashutosh, we are running out of time. I'll just have to cut you here. We had a question coming up from the organizers that in this difficult times of COVID pandemic, where as clinicians you need to actually spend a lot of time one-on-one with the patients. How is telemedicine affecting psychiatry? in the sense how difficult it is discussing a patient's complaints and profiles via telemedicine rather than having him face to face discussing the clinical complaints. Are you finding the new normal a bit difficult to handle, or is it just going with the flow?
Well, the new normal is no more new.
That's
It's more
true.
than half a year now since we are in this so-called new normal. So
Yeah,
Yeah.
there was a learning curve. So let's say in end of March and beginning of April, when there was a disruption, at least in India and in most parts of the world, when every physical OPD switched over to this virtual telemedicine OPD. So in the beginning, there was a lot of issues pertaining to technical connectivity. Sometimes, I mean, today we are having a good speed, we can see each other, but really in the physical OPD, we are having a look at the patient overall. Here you are just seeing maybe my face. I've had where the patients bring the phone so close, I'm just able to see the forehead, or I'm just seeing the ceiling. So in the beginning, I had to tell them that please adjust the camera so that I can at least see your face. Because
so
we
the
tend
struggle
to,
started from there.
yes, this was the real difficulty. And mind you, at least in India, my experience was most of our population are smartphone savvy, be it the young, be it the old.
I agree.
Everybody is on WhatsApp. So
Got
that
it.
has been a boon that the population did not have a learning curve using telemedicine. So people were aware of it. Of course, there could be connectivity issues in some parts of the country. So sometimes we may not get a proper picture or a proper voice. But the
Got it.
biggest deficiency was the in-person face-to-face. You know, when we are looking at the patient, we are looking overall. How fast is he walking? What are the mannerisms? What is the body language, which we completely miss out in
Exactly, exactly.
telemedicine?
And that's precisely why I wanted to ask this question as to how are you finding the new normal?
Yeah, but having said that, the plus point was we are sitting unmasked, so we can really observe the facial expression. Whereas, assuming that it was a physical OPD, we would have been wearing a mask, so will the patient. So, definitely, we cannot see the facial expression. So, that's
Yes.
another disadvantage of seeing in the physical OPD. And another good point for telemedicine, some of my patients who were coming from outside Mumbai, you know, they could jolly well sit in their house, maybe even in Assam, and contact me. So that was
Yeah.
the geographic distance was out, and
Yeah.
this was another advantage, I would say. And the government of India actually did a very good step of promulgating the telemedicine guidelines in end of March, which
Okay.
really benefited that we could previously, prior to that, telemedicine was kind of question mark legal or illegal. There was no clarity about that point.
Yes. Yes.
Now it has been formally legalized. Of course, it's not yet an act, it's just a gazetted notification. But the good point was we could write a prescription, upload a photograph for the patient, and this can be honored by the chemist. So there were a lot of things which worked during the pandemic. There was a learning curve. I would say at least the first 5 to 6 weeks, it was not very comfortable. If we get a new case, it was really not very comfortable doing the consultation or working on the treatment. But I think over a period of time, we have adapted. Patients have also adapted. In fact, none of my patients have yet told me that they would like to see me in person in the physical OPD. Of course, there was a question, but beyond that, there was no insistence because there is a fear for the patient, there is an inconvenience for the patient, and these factors work. Having said that, I don't think that telemedicine is going to be permanent. At some point in time, there will be a hybrid model where we can have a face-to-face OPD and then
Mhm.
followed by some consultations through telemedicine, and then again at a periodic interval, again face-to-face. Specifically
Got it.
for the
Got it.
chronic medical condition, this
Yeah.
may be the model for future, but it's too early to say if this is the case.
Yeah. Then we will have to wait and watch the way this unfolds.
And see, one point, Ritesh, which I also was about to tell Neha also, is that be it a psychiatrist or a non-psychiatrist, one thing that we should not compromise is the time that we give to the patient.
Agree.
So
Yeah.
you cannot have a consultation of 5 minutes or 10 minutes, definitely not in psychiatry, or even 15 minutes. If
Yeah.
it's a new case, I'm going to be spending at least 45 minutes to maybe an hour. The idea, and this is what differentiates psychiatry from all other specialties, we are looking at who is this person that is having this illness, rather than what is the just the illness that this person is having. So we are looking overall. So we are taking into account what is this guy or girl, what is their personality, what is the environment, and then what is their problem. So we kind of integrate that. Whereas another medical specialty, they are just bothered, okay, is the heart working well or not? We are not bothered about anything else. This is what differentiates. And to do this, we need time. And listening is therapeutic. So it's not just what we tell, it's also giving a patient active listening, making the person
Very much.
feel that there is somebody who's trying to make sense of what is happening to them. That itself is therapeutic. So, suddenly the clinician may have a patient telling him, Doctor, you heard me and I'm feeling fine. And the doctor is wondering, how can that be? No, it is possible.
That's true.
Patient active listening. So sometimes we know that we cannot do much for the individual, but just give our time and attention. That itself is therapeutic. So in
Yeah.
a pandemic, telemedicine may be sometimes a little bit taxing because you cannot have a lot, patients assume that because you are on the phone, they can have a lot of your time. So some boundary settings will have to be there.
Yeah. And listening is a skill also.
Well, it's a
All of
skill.
us as doctors have to develop that talent to be good listeners.
Yes,
Because
but
all
for
of us are
that,
good in giving advice, but we need to be good listeners also.
yes, for that we need to be non-judgmental. If we have preconceived notions that, okay, I know this, at least at a family doctor level, I know this
Yes.
family, they're always like this only, always cribbing. We should not have those preconceived notion or a set bias as we call. Give them the opportunity. Of course, then we need to have a boundary setting. So what is accepted, what is not accepted needs to be gently told. And this comes over a period of time. And actually, one point which Dr. Neha said, which stands out from all other internists, she did a specific internship in psychiatry. And this is something I will strongly advocate. You see, at a graduate level, that is MBBS, at least in India, I think the internship in psychiatry is what, 15 days?
Yeah. 15 days. I'm talking
15
about
days.
1999. So 15 days.
Yes.
Yeah, it
Because
was.
when I did my internship, it was in 96. It was
Yeah.
only 15 days. The
15
only
days.
thing
I
I,
agree.
only
And
thing
third
I,
MBBS psychiatry paper was about 15 short notes in psychiatry. So all you have to do was read up about 50 short notes, out of which 15 short notes came in your papers.
right.
So
So,
those were the days. I think Dr. Abhijit is here, and we must have overshot our time. So he's seeing us watch again and again. Abhijit, you want to share something?
No, no. It was a great talk. I listened to all of it, and I totally agree. I heard the feedback from Dr. Ashutosh about telemedicine, and would love to hear from New Yorker Neha. That was where the epicenter of the COVID in US started. So, Neha, if you could share your experience with telemedicine with your patients.
Yeah, no, absolutely. I think I agree with what Dr. Ashutosh said. There was definitely a learning curve, but now that is kind of the norm. And not to pitch psychiatry versus internal medicine, but I think psych over telemedicine is easier. I will say that as opposed to internal medicine consults, because physical exam is really important in our specialty to be able to
Right.
actually see and in person and touch and hear and listen to the lungs and all that. So it's definitely more tricky, but and it's somewhat limiting in that sense, but the technology has taken off so much with patient monitoring systems now that patients can actually wear, and their actual heart sounds are transmitted to your computer. Their vitals are transmitted, so you are actually able to see and hear all that live as you're looking at the patient. So it's been amazing, and the access is very important. I think a lot more people have access to medicine, especially psychiatrists and mental health specialists. It's enormous. We have several telemedicine platforms that provide even psychotherapy via telemedicine. So not just psychiatry, but therapy sessions online. And these are they are very popular because, as you said, it's safe. You can sit without your mask. You can sit in the comfort of your home and actually talk to someone. And a lot of times it's about having that person hear you, having somebody listen to you. So it's extremely valuable. It's reimbursed by insurance companies. Telemedicine, in fact, the visits are now reimbursed at the same rate as if they were in person. So we have, that was a big change in the reforms that promoted telemedicine. Because let's face it, if you're not going to be paid for your hours worth of time, it's difficult to keep doing that every day. So I think a lot of grassroots level law changes in reimbursements were made to facilitate telemedicine as a platform, and having access in these difficult times to health providers and mental health specialists is so important. And I congratulate you for being able to do your work via telemedicine. I do consults all the time, and it's the learning curve, but I think it's a blessing. And as a surgeon, I think it's different, but if you're in a medical specialty,
and I agree. As Dr. Ashutosh also said, it's going to be there, but not permanent, but it's going to be a hybrid model. And I think for every specialty, the cases will be separated, which one you can do through telemedicine, which one you have to see them in person. So
yeah, in fact, they're giving that choice now. We are asking patients if they want to come in person or they want a televisit. So when they call to schedule, they are given that choice. So they're welcome to come. If they're not comfortable, we can see them over telemedicine. So yeah, it is definitely looks like a hybrid model as of now.
Great. No, it was a great talk, and thanks to everyone, and welcome to MD Talks.
So Abhijit, just before you say the final cut, I just want to ask both of them, how do psychiatrists let the hair loose on a Saturday evening after a stressful day?
Well, you are asking me?
Both of you.
Well, Saturday morning here, I had to cut short my Friday evening, I have to say.
And just kidding. Basically, I thought both of you gave quite a lucid and informative talk, and which would be quite useful for not only to the patients but also to the doctors. And Abhijit, you want to add something to that?
No, it was as an internist or a hospitalist, I was listening to it very carefully because a couple of cases I feel that I could use that information right away. So I think it's day-to-day practice. Everyone has some of the other issues, whether it's a normal patient or diagnosed patient. So it's always, good to know more about it. And agree with that 15 days, residency or the internship thing. I don't even remember those 15 days. Half of them were either running around with, different lectures from different residents, and then psychiatry is the easiest way, or the patient will pull you out. So, so having that, bigger exposure, I think, during the medical school would help a lot. Yeah.
Absolutely, yes.
Yeah. So I would like to thank MD Talk for giving this opportunity to getting us together for a discussion on depression. And I'm sure all of us would like to meet up in future personally too.
Yeah.
Thank you.
Take care. Thank you, everybody.
Have a good weekend. Bye-bye.
You too.
Bye.
Bye.